Everyone. Today, we're going to tackle a really foundational topic for your journey in medicine: antiadrenergic drugs.
That's right.
Think of this as your essential guide, sort of understanding how these medications work and, when you'll actually be using them in your clinical practice.
Yeah, exactly. Here on KMR Advise, our goal is really to take this, often complex world of pharmacology and just make it clearer, make it useful for you.
Mm-hmm.
So today, we are diving deep into antiadrenergic drugs. We'll explore their uses, the ways they work in the body, which is fascinating, and the critical things you absolutely need to keep in mind.
Right, when considering them for patients.
Yeah.
And we've got a great overview lined up. It covers, everything from how these drugs are classified, their mechanisms, right through to side effects and those invaluable clinical pearls you pick up.
Absolutely. So if you're looking to build a really solid understanding of this important drug class, yeah, you're definitely in the right place.
Okay, so where should we start? Maybe jump right into where these drugs are used.
Good idea. Let's see where these antiadrenergic drugs actually fit in clinical practice. You might be surprised by the sheer breadth of conditions they help manage.
Yeah, it really underscores their importance, doesn't it?
It does.
You'll encounter these across, a really wide range of scenarios. Let's maybe start with hypertension, high blood pressure.
Okay.
We're talking about meds like propranolol, that's a beta blocker, and clonidine, which is an alpha-2 agonist.
Right. Two different approaches there.
Exactly. Both key players, but working through different mechanisms to get that blood pressure down.
And expanding on that, you've got benign prostatic hyperplasia, BPH. Tamsulosin is very common there.
Oh, yeah. Tamsulosin, alpha-1 blocker, right?
Correct. And the interesting thing there is it specifically targets alpha-1 receptors, mainly in the prostate and bladder neck. So you get a more, let's say, targeted effect.
Less systemic, maybe?
Potentially, yeah. Then there's pheochromocytoma. It's less common, sure, but critical.
Right. That tumor-releasing catecholamines.
Exactly. And phenoxybenzamine, a non-selective alpha blocker, is often vital preoperatively. Very specific but crucial use.
Okay. What about migraines?
Ah, yes. Migraine prevention, we see beta blockers again, propranolol, timolol.
It's kind of remarkable, isn't it, how one class, like beta blockers, pops up for blood pressure, migraines.
It really is. Shows how receptors are involved in different body systems.
And heart failure management, that's a big one.
Huge. Carvedilol comes in here. It's a mixed alpha and beta blocker.
And that dual action is key, right?
Absolutely. It offers significant benefits. And as we'll touch on later, it's actually proven to improve survival rates in heart failure patients. That was a real game changer.
Wow. Okay. What else?
Well, another fascinating area is opioid withdrawal.
Clonidine again.
Clonidine again, that same alpha-2 agonist we mentioned for hypertension. It can really help ease some of those really unpleasant withdrawal symptoms, sort of calms down that overactive nervous system response.
Makes sense. And glaucoma. I know timolol eye drops are common.
Yes. Timolol, another beta blocker, frequently used topically for glaucoma. Our source focuses more broadly, but yeah, that's a key use.
And then, emergencies. Hypertensive crisis.
Right. Need rapid action. Labetalol, another mixed alpha-beta blocker, is incredibly valuable there because it works quickly.
Got it. Any others?
One more to mention is Raynaud's phenomenon. You know, where the fingers and toes get really cold and change color?
Poor circulation.
Exactly. Excessive constriction. Prazosin, an alpha-1 blocker, can help by relaxing those blood vessels and improving flow. So you can see it's a really versatile group. You'll definitely be seeing these a lot.
Okay, so that's a good overview of the where. Now let's maybe dig into the how. How are they categorized? Understanding the classification, I think, gives you a good framework.
Exactly. A mental map. We can group them based on, which receptors they hit or how they fundamentally work. First up, the alpha-1 blockers.
Like prazosin and tamsulosin we just mentioned.
Precisely. And for listeners familiar with brands in India, you might see Minipress for prazosin or Uramax for tamsulosin.
Okay, next.
Then, the alpha-2 agonists. Key examples here are clonidine and methyldopa.
Brands like Ketapres or Aldamet in India, perhaps.
That's right. You might encounter those names.
Then the beta blockers. This is a big class.
It is. We can subdivide it. Let's start with non-selective beta blockers. Think propranolol, timolol.
Indian brands like Ciplar, Timoptic, maybe?
Yep. And non-selective means they block both beta-1 and beta-2 receptors. That's important.
How is that important?
We'll get to that, but it relates to side effects, especially in the lungs. So, following non-selective, we have the beta-1 selective blockers.
Like metoprolol, atenolol.
Exactly. Common brands in India might be Betaloc, Tenormin, and that selectivity is really important clinically. Can mean fewer side effects for some patients.
Okay, makes sense. What else?
Then there are the mixed alpha-beta blockers. Carvedilol and labetalol are the main ones here.
Brands like Carlock, Trandate.
You got it. And finally, a slightly different group, the adrenergic neuron blockers.
Rizopine, guanethidine, like Serpacil, Ismlin.
Yes. These work a bit differently, more upstream, affecting the neurotransmitter release itself.
Okay, classification down. Now, maybe some key points about these classes, the sort of must-knows.
Let's do it. Starting with those alpha-1 blockers. The big effect to remember is vasodilation widening blood vessels.
Which lowers blood pressure, helps with BPH flow.
Right. But the flip side is that it can cause first-dose syncope, that sudden dizziness or fainting when standing up.
Ah, the postural hypotension effect.
Exactly. And that's something you absolutely need to warn patients about. Tell them to get up slowly, especially after the first dose. Prevent falls.
Crucial counseling point. Okay, beta blockers.
Key things here. Contraindications. Asthma and heart block are the big ones.
Why asthma?
Because non-selective beta blockers can block beta-2 receptors in the lungs, causing bronchoconstriction, worsening asthma.
Okay, and heart block.
They slow down the heart's electrical conduction. If someone already has heart block, beta blockers can make it dangerously worse.
Got it. But there's a positive point too, right, with carvedilol.
A very positive point. Carvedilol, specifically, is proven to improve survival in heart failure. That's huge. Based on landmark trials, it fundamentally changed how we manage heart failure.
Wow. Okay. And clonidine, the alpha-2 agonist.
Right. Its main action is central in the brain. It activates alpha-2 receptors there, which basically tells the body to decrease sympathetic outflow.
Less fight-or-flight signals.
Exactly. Less norepinephrine release overall. That's why it works for both hypertension and, as we mentioned, easing those opioid withdrawal symptoms.
Okay, this is great. Now let's really get into the nitty-gritty. The mechanism of action, the MOA. How exactly do they work? Step by step might be good for exams.
Good plan. Step 1, receptor interaction, where the drug meets its target. For alpha-1 blockers like prazosin,
They block alpha-1 receptors on blood vessels, right?
Precisely. Stops norepinephrine from binding, prevents vasoconstriction, blood pressure goes down. Simple as that.
Okay. Alpha-2 agonists, clonidine.
That interaction is central in the brainstem mainly. They activate alpha-2 receptors there.
Agonist, not blocker.
Right. And activating these receptors acts like a brake, reducing norepinephrine release systemically. Lower sympathetic tone.
Okay. Beta blockers.
Propranolol. They block beta-1 receptors, primarily in the heart. This reduces intracellular signaling, specifically CMP levels.
And the result is?
Slower heart rate, less forceful contractions. But remember, non-selective ones like propranolol also block beta-2.
Lungs, right. Potential for bronchoconstriction.
Exactly. And finally, for step 1, those adrenergic neuron blockers like Rizopine.
They work differently, you said.
Yeah, they don't block the receptor directly. They mess with the storage of norepinephrine inside the nerve ending. They deplete the stores.
So when the nerve fires, there's less neurotransmitter to release.
You got it. Less fuel for the sympathetic signal.
Okay, step 1 down. Now, step 2, clinical effects. How does that receptor interaction translate to what we see in patients?
Right. Let's take tamsulosin. By blocking alpha-1 receptors, specifically in the prostate and bladder neck smooth muscle.
It relaxes those muscles.
Exactly. Improves urine flow. Directly helps with those obstructive BPH symptoms.
Makes sense. Propranolol. How does blocking beta-1 help angina or migraines?
For angina, by reducing heart rate and contractility, it lowers the heart's oxygen demand. Less work, less pain if blood flow is limited.
Okay. And migraines.
That's a bit more complex. Likely involves effects on blood vessels in the brain, maybe some nerve signaling modulation. Not fully understood, but it works for prevention.
Interesting. And clonidine for withdrawal.
By reducing that overall sympathetic hyperactivity we talked about, it directly alleviates symptoms like sweating, tremors, agitation, makes withdrawal more tolerable.
Got it. So that's the effect. What about step 3, termination? How does the body get rid of them?
Right. Pharmacokinetics basics. How long do they stick around? Propranolol, for example, is mainly metabolized by the liver.
Specific enzyme.
Yes, CYP2D6. That's important because other drugs might compete for that enzyme, affecting propranolol levels.
Good point. Clonidine.
Primarily renal excretion. About half of it leaves unchanged in the urine.
So kidney function matters for clonidine dosing.
Definitely. Need to consider that.
Okay, that MOA breakdown is helpful. Let's maybe formalize the pharmacokinetics a bit more. onset, metabolism, excretion for the key ones.
Sure. Good idea to have a clearer picture. This helps with dosing decisions, understanding duration.
So, prazosin.
Orally, onset is usually about 1 to 2 hours, metabolized in the liver, mainly by CYP3A4, excreted mostly via bile and feces.
Okay, clonidine.
Onset is quicker, maybe 30 to 60 minutes orally. As we said, about 50% metabolized by the liver, the rest excreted unchanged by the kidneys.
Propranolol.
Onset, again, around 1 to 2 hours orally. Liver metabolism via CYP2D6, eliminated in urine. Remember that CYP interaction potential?
Got it. And carvedilol, the mixed one.
Similar onset, 1 to 2 hours orally. Liver metabolism again, but uses both CYP2D6 and CYP2C9, excreted mainly in the feces.
So knowing these profiles really helps anticipate how a drug will act in a specific patient.
Absolutely. Tailoring treatment.
Okay, let's move to some practical advice. Clinical pearls.
Yeah.
The stuff that really helps in practice.
Love the pearls. Okay, one for clonidine. It's available as a transdermal patch.
Right, it sticks on the skin.
Yeah. Delivers the drug continuously over 7 days. Great for hypertension management, helps with compliance, gives stable drug levels.
Good tip. Another one?
Metoprolol. Remember we said it's beta-1 selective?
Yeah, unlike propranolol.
So it generally has a lower risk of causing bronchospasm. This makes it a safer choice often for patients who also have COPD. Selectivity matters.
Definitely, a key distinction.
And here's one that's like classic exam fodder.
Yeah.
Phenoxybenzamine for pheochromocytoma.
The pre-op drug.
Right. It's an irreversible alpha blocker. That irreversible binding is key to controlling the massive catecholamine release from the tumor before surgery. High yield fact.
Irreversible. Got it. Okay, now we have to talk about the downsides. Adverse effects.
Essential topic. Let's maybe categorize them by system. Makes it easier to track.
Good idea. Cardiovascular first.
Okay. Alpha-1 blockers like prazosin, we mentioned orthostatic hypotension, that dizziness on standing, direct result of vasodilation. Slow position changes. Beta blockers like propranolol can cause bradycardia, slow heart rate, due to blocking beta-1 in the heart.
And if the bradycardia is severe...
Might need atropine.
Okay, respiratory system.
Big one is bronchospasm, especially with non-selective beta blockers like propranolol.
Because of beta-2 blockade in the lungs. Especially risky in asthma patients.
Exactly. If it happens, nebulized albuterol, a beta-2 agonist to open the airways.
CNS effects, brain-related.
Clonidine commonly causes sedation, that central alpha-2 action again. Reserpine historically was linked to depression.
So management.
For sedation, maybe dose reduction. If reserpine seems to be causing depression, definitely stop it. Monitor mood closely.
Okay. What about metabolic effects?
This is subtle but important. Beta blockers can mask the warning signs of hypoglycemia, low blood sugar.
Like the shakiness, sweating?
Yeah, those adrenergic symptoms, they get blunted. Plus, beta blockers can inhibit glycogenolysis, the liver releasing sugar.
So particularly important for diabetic patients.
Critically important. They need more frequent glucose checks.
Right. Okay. Adverse effects covered. What about absolute don'ts? Contraindications.
Super important. Absolute contraindications first. Beta blockers generally avoid in active asthma or significant heart block.
For the reasons we discussed. Bronchospasm risk, slowing conduction too much.
Exactly. And reserpine contraindicated in depression because of that risk of worsening it or causing suicidal thoughts.
Okay, those are the must-avoids. What about use with caution? Relative contraindications.
Right. Situations needing careful thought. Prazosin, for instance, in someone already prone to orthostatic hypotension, it could make it worse.
Use cautiously. Monitor closely.
Yeah. Similarly, clonidine in someone who already has bradycardia, it could slow the heart rate down even further. Use with caution.
Got it. Always weigh risk versus benefit. Now, interactions with other drugs, that's always a minefield.
It really can be. Some key ones to know. Beta blockers plus certain calcium channel blockers like verapamil or diltiazem.
What's the risk there?
Additive effects on heart rate and AV conduction. Increased risk of severe bradycardia or AV block.
Okay, dangerous combo potentially.
Can be. Another one, clonidine plus other CNS depressants. Think alcohol, benzodiazepines, opioids.
Increased sedation.
Markedly increased sedation. Very important to warn patients about mixing them.
Definitely. And one more.
Tamsulosin, the BPH drug, combined with PDE5 inhibitors like sildenafil, Viagra.
Both cause vasodilation, right?
Exactly. Synergistic effect can lead to severe hypotension. Always get a full medication list.
Absolutely crucial. Okay, maybe some specific dosage examples now, and perhaps weave in a few more pearls.
Sure. Let's look at clonidine again. For hypertension, maybe 0.1 to 0.3 milligram twice daily, orally.
But for opioid withdrawal.
Dosage might be similar per dose, zero point 0.1 to 0.3 milligrams, but more frequent, maybe 4 times a day. And the crucial part is the taper. Gradually reduce over 7 to 14 days. Never stop abruptly.
That rebound hypertension risk again.
Precisely. Propranolol. Dosage varies a lot. Hypertension might be 40 to 160 milligrams twice daily.
Migraine prevention.
Often lower, maybe 20 to 40 milligrams 3 times a day. Shows how dosing depends entirely on the indication.
Right, and tamsulosin. Any dosing pearls?
Standard dose is usually 0.4 milligrams once daily. Often recommended to take it after the evening meal.
Why evening?
May help minimize that potential dizziness or orthostatic effect.
Ah, good tip. And any specific pediatric warnings?
Yes, important one. Avoid clonidine in neonates, newborns. There's a risk of apnea pauses in breathing.
Definitely need age-specific considerations. Okay, what about worst-case scenarios? Toxicity and management.
Need to know this for emergencies. Let's give a quick rundown. Beta blocker overdose.
Signs when in severe bradycardia, hypotension.
Exactly. Mainstay treatment, glucagon the fourth, maybe 1 to 5 milligrams. Also atropine to boost heart rate.
Clonidine withdrawal. We mentioned hypertensive crisis.
Right. Management. If possible, restart the clonidine immediately. Also, give labetalol the VA to control the blood pressure rapidly. Again, emphasizes why tapering is key.
Viscerpain toxicity.
Can manifest as severe depression, GI ulcers. Management is basically stopping the drug, treating the depression, maybe with antidepressants, supportive care.
Okay, let's wrap up with some really high alert items. Black box warnings, key takeaways on risks.
Good idea. Clonidine. That black box warning is specifically about rebound hypertension on abrupt withdrawal. Hammering this point home, taper slowly.
Viscerpain.
Black box warning for risk of suicidal ideation, reinforces the contraindication in depression.
And prazosin.
No black box, but that key note about first dose syncope, practical advice. Start low, 1 milligram maybe, and take it at bedtime initially.
Minimizes the risk if they do get dizzy.
Exactly. And let's reiterate that high yield fact one more time. Carvedilol reduces mortality and heart failure. Remember the Copernicus trial, it's a cornerstone therapy.
Excellent. Okay, so as we sort of conclude this deep dive for KMR Advise, let's quickly hit a final exam checklist. Key learning points.
Good summary. First, MOA. Understand the receptor effects, alpha blockade, beta blockade, alpha-2 agonism. Be specific.
Know the key drugs and their main uses, like clonidine for withdrawal, propranolol for migraines, tamsulosin for BPH. Associate drug with use.
Definitely know the major contraindications.
Yeah.
Beta blockers in asthma heart block, reserpine in depression, non-negotiables.
Know the antidotes or key management steps for toxicity withdrawal. Glucagon for beta blocker OD, labetalol for clonidine withdrawal crisis.
And finally, remember those clinical pearls, carvedilol's mortality benefit in heart failure, phenoxybenzamine pre-op for FeO, those high-impact facts.
All right, that really covers it. That brings us to the end of our deep dive into antiadrenergic drugs here on KMR Advice. We've gone through a lot today.
We have, from uses, mechanisms, side effects, all those clinical considerations.
We really hope this detailed breakdown has been helpful for you in your medical studies. Remember to review your notes. Think about how these drugs actually impact patient management day to day.
Yeah, connect the pharmacology to the patient in front of you.
And maybe here's a final thought to ponder as you go. Considering all these different mechanisms and effects we've talked about, how might a patient's other health problems, their comorbidities, influence your choice of antiadrenergic drug, even beyond the main reason you're prescribing it?
That's a great question. That interplay is where clinical judgment really comes in, isn't it?
It really is. Something to think about.
Well, thank you for joining us for this discussion. Definitely head back to the KMR Advise YouTube channel for more in-depth medical education.
Yes, please do. And if you found this useful, please share it with classmates. Subscribe if you haven't already, and hit that bell icon so you don't miss our next deep dive.